Listen now to a talk Ray Gibbons had with Dr. Ken Mahaffrey, Professor of Medicine and Vice Chair for Clinical Research at Stanford University School of Medicine in California. They cover reducing stroke risk in atrial fibrillation.
Welcome to ACCEL, Ken.
Thanks, Ray. Good to see you.
I think our listeners would enjoy hearing the update of where we stand from a guideline standpoint of how we should best assess stroke risk in atrial fibrillation.
Exactly. We've all known for a while that we do need to assess both the ischemic risk with stroke and systemic embolism as well as the bleeding risk when we're considering anticoagulant therapy in our patients with atrial fibrillation. The challenge is that we don't do that as often as we should. And many observational data sets have shown that. The guidelines for the management of atrial fibrillation from the ACC, the AHA, and the Heart Rhythm Society have really positioned nicely the need to perform risk assessments. For the first time in the ACC, AHA, and Heart Rhythm Society guidelines, they're focusing on the CHADS-VASc score rather than the CHADS-2 score. And so now, with the Class 1 recommendation is that all patients with AFib should be stratified for their stroke risk using the CHADS-2 VASc score. And also for bleeding, should use the HAS-BLED score that we're all familiar with. They're on iPad apps and smartphone apps. So let's start to use them and be consistent with the guidelines.
Well, I think that's an important point, and one that certainly the national data most recently has suggested there are major problems with from the standpoint of documentation of the use of the scores. And in your personal practice, are people using iPads or iPhones or Googling it? What do they do?
When I was at Duke, but now at Stanford, we really educate the house staff and the fellows to use the applications. If you can't remember what the scores are and be able to do it on the fly, then use a smartphone app, easily downloadable. There are also web-based tools. The Team A collaboration that the ACC is part of has all of these apps on that website. So yes, use them. And I insist that my house staff document those in their presentations as well as their notes.
I think people will be a little less familiar with HAS-BLED, which is something that certainly our European colleagues have been in favor of for quite some time. Do you want to give them a brief sort of overview of that?
HAS-BLED is a mnemonic for the following, and you get 1 point for each of these. It's hypertension. For H, A is abnormal renal or liver function. S is a history of stroke. B is leading liability. L is a labile INR. E is for elderly greater than 75 years of age. And D is for drugs of abuse, alcohol, and others. You get a point for each of those. The points actually then can be added up. You can look at the nomograms that can give you what the bleeding risk is. Now, the challenge of these scores and what we still struggle with is that they don't differentiate as well as we would like them to. Because as you see, many of the factors that go into the HAS-BLED score are also part of the CHADS-2 VASc score. And so often people at the highest risk for stroke complications are at the highest risk for bleeding, and likewise at the lower end. They can often help, though, if you're in the middle and help you make decisions.
Well, in terms of the decisions, I think the guidelines emphasize the importance of shared decision-making involving the patient. Can you give our listeners some perspective on that?
Certainly. So in the new guidelines, it's a Class 1 highest level of recommendation. It's a C weight of evidence, but it says that the patient should be part of the decision-making for anticoagulation therapy for atrial fibrillation. And I highly support that. The challenge that we have are twofold. One is we're all busy, and these kind of discussions take a lot of time, which is what we often don't have when we're in a busy clinic or in a hospital trying to take care of lots of patients. So I recognize that struggle that everyone has. The second is there are not a lot of good validated decision-making tools available to physicians and patients and their families. So I think that the work that's going in through PCORI and other funding mechanisms right now to develop these tools and more importantly validate them will then help us with these discussions with our patients and their family, make them more efficient, and allow us to then move on in the decision making and get patients treated the best way they can.
Well, having had some of these discussions in the last 24 months for sure, with the availability now of alternatives to warfarin. One of the points that clearly comes out in my discussions with patients is a concern about cost. Can you address that for our listeners?
Right. It is a big challenge, and I'm sure that many people listening to this, and both you and I have had patients that have said, I agree, these new drugs are either better than or at least as good as warfarin. They're easier to take, but doc, I just can't afford it anymore. I want to go back on the warfarin. Well, the problem is that warfarin has a lot of hidden costs as well that's just often easily taken care of through insurance and other payers that aren't recognized and covered when you go on these newer oral anticoagulants. I don't have the answer for you, Ray, but we need to figure out this as a society, because here we have a class of drugs, some of which have shown clear superiority to warfarin in reducing intracranial hemorrhage by 40 to 50%, decreasing bleeding, decreasing stroke. These are better drugs. We've got drugs in other classes, in the P2Y12 inhibitor class after acute coronary syndromes, that have shown mortality benefits, and they're still not getting used because of cost. It's a critical issue. Don't have the answers, but we need to sort it out.
The important thing here is to recognize that, as you've pointed out, there are certainly hidden societal costs in the use of warfarin, but what the patients tend to focus on is their out-of-pocket costs, when even in the presence of good drug coverage, they have a 20% out-of-pocket. And as I was pointing out to you earlier, I was amazed within the last 6 months to have a relatively affluent retired physician with drug coverage decide to stop his novel anticoagulant and return to warfarin because he didn't want to bear the out-of-pocket cost.
Right. That's just a sad example of where we are right now. And despite the fact that we're getting cost-effectiveness analyses performed with these drugs from the trial databases showing that these are very attractive in terms of the dollars required per year of quality of life saved, we can't put the burden of all of this on our patients. If you have the answers, I'd love to be educated now.
And I think our listeners all have some experience in struggling with this with their patients, so they should be aware. Now, you did mention the clear predominant benefit of the novel agents is a reduction in cerebral hemorrhage. That's unequivocal in all of the data. But we also have this sort of uncertainty because we have less experience with how to handle bleeding when it does occur with the agents and how to handle issues of surgery, for example. Can you give us some sort of insight and suggestions to our listeners as to how they can handle that in their discussions with patients?
Right, and this is the whole topic of needing an antidote. And remember, even with warfarin, we really don't have an antidote. Vitamin K can reverse it, but it does it over a period of time. It's not acute. What I often tell people when I'm reviewing the data or patients is that the trial data that we're seeing was done without an antidote. And the results that we see are very favorable without that antidote. In fact, we've gone back and looked. In these, what I would call relatively elderly populations with a lot of comorbidities, there are literally thousands of times the drugs are interrupted for procedures. In the Rocket AF trial, for example, there were over 7,000 temporary interruptions of about 4 to 5 days for elective surgeries. And it was done very smoothly. You stopped the rivaroxaban 2 days before the procedure and then started it afterwards. So this can be done safely in the elective setting. In the more acute setting, then obviously you need to stop the drug. You need to try and reverse with blood products as necessary. Make sure you're not seeing any problems with other antiplatelet or other antithrombotic therapies that may be on board. And then finally, all of the sponsors or pharmaceutical companies that manufacture these new agents are pursuing programs to develop antidotes or reversal agents, and we'll see those in the future, which may give the clinical community a little bit more comfort.
Well, we'll look forward to those when they're available and to having you come back. But in the meantime, I think you've given our listeners some insight into how they should assess risk, have a good discussion with their patient about the decision regarding the drugs and how they should present some of the difficult issues for the novel oral anticoagulants. Thanks for coming to ACCEL, Ken.
Thanks for having me.